Hi, this is Rachel Dillinger with the American Journal of Psychiatry Residence Journal podcast. I'm a resident at the University of Maryland Sheppard Pratt Psychiatry Residency Training Program in Baltimore, Maryland. I am hoping to speak today with Dr. Neil Sandson. He is a fellow Temple School of Medicine alum and a known drug interaction guru at our program. I would like if he could possibly introduce himself.
Hi, I'm Dr. Neil Sandson. I'm an associate professor on the volunteer clinical faculty at the University of Maryland, and I'm also the director of hospital-based services within the psychiatry department of the VA Maryland healthcare system. I've been involved in teaching residents within the program, both didactically, clinically, and administratively, really for the last 23 years. And I got interested in drug-drug interactions as a topic starting around that time. I went to an APA meeting in 1996 in New York that was really eye-opening. And as a consult liaison psychiatrist fresh out of residency, I was very much struggling with how to deal with all of these delirious patients and get a handle on how and why their mental status was being acutely deranged. And it quickly became evident to me that this was a very important and very complicated topic. So I've been immersing myself in it for a number of years. The program here at University of Maryland has been very indulgent and allowed me to set up a drug interaction module to teach this to residents for the last many years. And I was hoping to share some of that with all of you who are listening.
So I didn't realize that most people don't take quite as deep a dive into drug-drug interactions outside of our program. I thought it was a lot more universal. I know everybody pretty much, can think of a few illustrative things like carbamazepine inducing its own metabolism, but we do a lot more thanks to you. And I was hoping you could share with our listeners why they should care about this.
Okay, it's a great question. And it's really the question that's asked with a somewhat different spin by the multitudes of physicians who would just as soon not worry themselves about this. Many people say, look, I don't muddy my brain with all of this stuff and my patients don't keel over left and right. How important can this be? And while it is certainly the case that our patients are resilient enough to tolerate the slings and arrows that we inadvertently throw their ways by virtue of what we aren't recognizing and aren't preventing in terms of drug interactions, nonetheless, we can certainly do better for the patients who are on complex regimens, who are fragile in various ways. The reason I would maintain that this is a worthwhile field of endeavor to take on is that I would say about 5% of the time when you're doing standard things, maybe 10% of the time, you encounter peculiar, idiosyncratic, unexpected results, whether it's success in a way you didn't expect it or lack of success when you were expecting success, whether it's a bizarre side effect. And we have a tendency to write these off as unpredictable, bizarre, idiosyncratic patient-specific interactions or reactions, when really a significant percentage of the time, these unpredictable outcomes are actually the predictable and anticipatable consequences of drug interactions. And mastering this paradigm will allow you to avoid many of those pitfalls that most people will otherwise plunge into at the expense of their patients, of course. And it's not going to be most of your patients for whom this is a clinically significant issue, but it's going to be a critically important issue for a smaller percentage of your patients enough of the time that suffice it to say, it's highly gratifying to be one of the people who isn't going to avoidably inflict those consequences on one of my patients. If you're one of the 10% of clinicians who is hip to this paradigm, who is on the lookout for drug interactions, you can be that person who spares your patient the outcome that 9 out of 10 other people aren't going to spare that patient. So it's a worthwhile thing to grapple with and understand if you want to go past being merely good enough, if you want to try to do the best you can for each and every one of your patients, and not just most of them, but virtually all of them, This is an indispensable tool as part of your pharmacotherapeutic armamentarium.
So that sounds like a worthwhile endeavor to me, almost like a real responsibility that we would have for our patients to be attuned to this body of literature and knowledge. I understand you didn't get super into it until you were in attending. Can you think of any cases when you look back, any patients you had when you were in medical school or residency or just starting out that you thought, oh, this is what was going on in that case?
That's a great question. It's interesting. I certainly had times where, well, there was one time in particular where I will never know whether a given patient unfortunately passed away because a the person who was performing a liver biopsy nicked a vessel and the person bled out, or was it because I had not thought to specifically inform the surgical team that the Depakote that they were on was going to affect coagulability, and that might have played a role for that patient. So tragically, yes, that was one of those times where I retrospectively thought back and said maybe this was something that I could have prevented if I had been more attentive, more alert. And it's interesting because that was trickling around in the back of my head, but I just didn't think to really feature that prominently. And then there was that outcome. More frequently, I really got into this so early in my career that what's happened more often are these sort of aha moments where I'll encounter something that has previously been written off as inexplicable, and it'll be like, oh, I get it, that's what's going on. So I really don't want to pat myself on the back too much, but that's really the fun part, is avoiding the problems or figuring out what went wrong so that you can avoid it in the future as a consultant, or when other people have unfortunately not picked up on those potential difficulties. I can give you one example as a consultant where someone came to me with bipolar disorder, having been placed simultaneously many years ago on venlafaxine and lithium, and had a generally stable course. And then their current treating psychiatrist decided, for reasons not relevant to this narration, that they wanted to have them transition to lamotrigine monotherapy. And the first step in this process was a tapering and discontinuation of the venlafaxine. The patient basically suffered from a serotonin withdrawal syndrome, which is not uncommon coming off of venlafaxine, but more curiously and much more challenging to explain was the enormous polyuria that the patient immediately encountered at the point where the venlafaxine was discontinued. They were really getting volume depleted and becoming quite miserable. The patient on their own put themselves back on the venlafaxine, and the case got semi urgently referred to me for consultative input. And again, so the patient was out of the woods, but I had this aha moment of, oh, I'll bet that what we had was SIADH from the venlafaxine that had never been recognized up to this point. And because the person had never previously been on lithium without the venlafaxine, the diabetes insipidus that the lithium would have produced had it ever been given as monotherapy was now unmasked by the discontinuation of the venlafaxine. And so my contribution was then to say to the next person that, well, first off, for other reasons, I didn't think it was necessary to go to lamotrigine monotherapy. But if that or some other maneuver was ever thought to be appropriate, transitioning off of lithium or off of venlafaxine would have to be accompanied by a transition off of lithium. They were going to have to be in tandem, or I suppose you could get off the lithium first and tolerate a little SIADH, but you couldn't get off the venlafaxine and keep the lithium there without producing a diabetes insipidus event. So that was so. But it's funny, if you're not on the lookout, if you're not thinking about these things, it's easy to just shrug and say, "Wow, who knows? That's weird." And then, of course, you move on and try to do something different, and often that's helpful. But it's always more helpful to understand what happened and why.
Despite not being flashy, it sounds like it would really be pretty gratifying thing to get into.
I think that's exactly right. I think we're looking. We see the tops of a lot of icebergs and glaciers, and don't appreciate what's under the surface.
Thank you for sharing those. So, for the people who want to be attentive and alert and attuned to this body of knowledge, where would be a good place for them to start?
Um, that's a really good question. So, part of how I did it was I went to some very influential lectures, as I mentioned, which got me carrying a P450 table with me. So it was an abbreviated table. It was two pieces of paper. Folks can use their auxiliary brains and pull it up on their cell phones if they want. But it basically is just a look at the various cytochrome P450 enzymes, and we can get into what all that means later, and the substrates, inhibitors, and inducers of those enzymes. And I just kept that with me. And every time I was doing a consult or admitting a patient, one of the first things I would do would be to look at the medication list and cross reference that with my tables and sort of teach myself gradually to recognize the pertinent and recurring interactions. And so for the first several dozen times, it was definitely an arduous, almost thankless process. I really felt like I was slogging through a quagmire, and none of this was really cohering or gelling. I was just doing this piecemeal each time, having to recreate the wheel. But after about 50 to 100 iterations of this, which goes a lot faster than you'd think it does, I started to see the patterns and I stopped seeing the irrelevancies, and I could devote my attention to the high yield areas. And after a while, it got more natural and I didn't have to look everything up every single time. And it became much more efficient. And best of all, it became part of me. I didn't have to think about it so much. It became just one of those natural things that I understood about the medications, besides their mechanism of action and the intended therapeutic usage. This auxiliary domain of how they're metabolized and how they affect other drugs' metabolism became part of that core informational set for the drugs that I was using frequently or encountering frequently. And so it became less and less of an effort. So, what do I recommend for other people? Keep a P450 table with you. You can worry about related systems like glucuronidation and Pglycoprotein pumps later. Start with P450, and that'll be a good entry. Of course, I've written a couple books that provide case vignettes for the drug interactions to make them friendlier and more approachable. I don't really want to hawk my own wares here. So I'll leave someone else. It doesn't have to happen, whatever. But yeah, there's a lot of good websites. And there's drug interaction programs, which are certainly a lot better than nothing. But I always have sensitivity and specificity concerns about even the best of those programs.
So at university and Shepherd Pratt, we have the benefit of having a whole course of this stuff with you, over the course of hours that I'm sure we're only probably just grazing the surface on what we should know and could know. So in the confines of a podcast, what high yield and useful information, knowledge do you think that you could share that would be really useful for people and maybe whet their appetite?
So I'd say the highest yield information is regarding low therapeutic index drugs, drugs where blood level increases are going to be much more apt to produce toxicities, whether that be in the context of drug overdose or, in this topic, drug interactions. So things like tricyclics, lithium, narcotic analgesics, uh, cyclosporin, tacrolimus, sirolimus, drugs like that. Those are drugs where, many of them, like the ones I just mentioned, don't cross a psychiatrist path that often unless you are doing consults on a transplant service. But certainly know the drugs that you use frequently, know them well, and know the drugs where you can get into trouble, the low therapeutic index drugs. I think that's a good place to start. Knowing frequent events that are going to happen, like smoking discontinuation when people are admitted onto an inpatient unit. That's an important paradigm to latch onto if that's the kind of work you're doing as a psychiatrist. So it pays to know what drugs are affected by tobacco smoking. And by the way, it's not nicotine, it is smoking tobacco that produces that drug interaction. And just to spill the beans, it's induction of P451A2 is accomplished by inhaling polycyclic aromatic hydrocarbons that are when you ignite and inhale tobacco products and, yes, cannabis. So when you start smoking, you're going to induce those enzymes and drop the levels of drugs that are substrates of that enzyme. And if you're going from a smoking to a non smoking setting, like being admitted to the hospital, then substrates of those enzymes will have a significant increase in their blood levels with discontinuation of the inducer, which is to say, you stop smoking. And conversely, if one starts a medication as an inpatient and then you transition outside the hospital and resume smoking, any drugs that were initiated that are substrates of that enzyme again are going to experience a decrease in blood level with the initiation of smoking, which could lead to a relapse and hospital readmission. So that would be an important thing for inpatient doctors to be aware of. There are drug interactions that deal with prodrugs. Prodrugs are all around us, more than we would ever suspect. There are drug interactions dealing with analgesic medications, and certainly those are important for patients who are counting on analgesia from their drugs. So those would be among the most important things to be acquainted with. Certainly, patients for patients, there's very little that is as high stakes as pain relief when they are experiencing acute and significant pain.
And I think that really brings up a good point. A lot of our patients' psychiatric illness doesn't exist in a vacuum, and there are often a lot of medical comorbidities, making it really critical to be aware of this stuff.
Exactly, exactly. So, just for instance, several of our medications like codeine, hydrocodone, and tramadol, although I'm less certain of tramadol, all rely upon the intact functioning of P452D6 to be transformed from codeine to morphine, from hydrocodone to hydromorphone, otherwise known as Dilaudid, and from tramadol to a metabolite that's a much more potent mu agonist. In 7-ish% of the population that lacks this enzyme, you're not going to see those transformations, and these drugs won't work that well for these folks. And in virtually anyone who's being co-administered a potent 2D6 inhibitor like fluoxetine or paroxetine, or ritonavir or any number of other medications or bupropion. These are all medications that will significantly impair that transformation and accordingly will often prevent effective analgesia with those medications.
Do you have any other illustrative examples to share?
Let's see. I don't want to get too esoteric. I'll sort of cover a few that are pretty common but important. Oral contraceptives. 1/4 of all women take them. Or actually, let me put it this way: ethinyl estradiol, whether it's oral contraceptives or hormone replacement in later life, consumed by 1/4 of all women, so 1/8 of the population. These drugs are so often involved in drug interactions. They're substrates of P453A4, so co-administration with various anticonvulsants and other inducers of that enzyme is going to drop these into subtherapeutic levels, producing, in the case of oral contraceptives, unintended pregnancies. These drugs also can have inhibition. They can be affected by inhibitors, producing breakthrough bleeding and such, I believe. Also, ethinyl estradiol itself is an inducer of the main phase 2 enzyme that metabolizes lamotrigine. And so it will drop lamotrigine levels 50%. And that can be meaningful in any number of ways. We've talked a little bit about smoking, warfarin drug interactions, or even in the era of rivaroxaban, we still see plenty of patients on warfarin and need to be acquainted with these issues. Gosh, there's so many to choose from. It's hard to be specific. I can tell you of one actual case of an older woman who she was on a number of medications. She was on a tricyclic antidepressant for sleep. I think it was amitriptyline. She was on warfarin and a number of other things, but those were the two main ones that were involved. And because she presented with more depression, her internist started her on fluoxetine, Prozac. This increased the levels of both the amitriptyline and the warfarin, leading to both expansion. So her bladder neck constricted. So her bladder filled up with urine because she had urinary retention from the anticholinergic effect of the tricyclic. Then, because the increased INR from raising the warfarin levels made her vessels that much more fragile and suspect to hemorrhage, she basically bled into her distended bladder and got into a critical state of affairs. So that would be a complex, multifactorial drug interaction um, that is unfortunately, I wouldn't say it's particularly common, but happens not horribly infrequently because a lot of people have this idea that, well, SSRIs are great. They never hurt anyone. Sure, throw Prozac at someone. Why not? But there's a lot to consider with this drug. It's a pan inhibitor. It inhibits the metabolism of virtually every phase one enzyme that we're concerned about in terms of the P450 family. Gosh, some other good vignettes. There's plenty of them.
Yeah, I feel like our radar really goes off when we see a laundry list of medications for patients, but you've just given multiple examples of how just two or three medications can really interact significantly and cause adverse outcomes for patients. Now, most people are at least aware of P450, but I was hoping you might be able to share some of the knowledge about phase one and phase two and how that relates to those.
Sure. So, phase one enzymes are oxidative, so they involve electron loss. And for most of the psychotropics that we take, phase one metabolic activity is going to constitute the primary inactivation step in terms of clearance of the medication. Phase two metabolism is occasionally the predominant inactivation pathway, but for the most part, what it's going to do is take the products of phase one metabolism and make them less lipophilic and more hydrophilic, more polar, and thus more readily excretable in our various excretory media, whether that's urine, bile, or feces. So that's what phase one and phase two metabolism basically are. The P450 system is really the phase one workhorse. It is the most important system involved in detoxification and inactivation of the various medications we take, whether for psychiatric or, for the most part, other purposes. There are other systems, but P450 is the most, really, I would say, the most important of them.
Another area I wanted to get into in P450 has to do with how we learn about the specific things, enzymes that metabolize drugs like risperidone and 2D6. But you had told us that the concentration of these isn't actually all equal in the liver. So I was hoping that you might be able to talk a little bit more about that.
Sure. I'm so impressed you remembered that part. So, for instance, P453A4 constitutes about 40% of the enzymatic complement of the liver. And so it's going to be very hard to take this enzyme entirely offline. Even potent inhibitors are not going to really produce a state of true lack of 3A4. It will, overall function will be deranged such that you'll have significant elevations of 3A4 substrates, but you're not really going to see um, people getting Cushingoid because they can't metabolize endogenous 3A4 substrates and such. Um, so there's a lot more capacity there. And whereas 2D6, which has a lot of important substrates and is an important enzyme, only constitutes about 1 to 2% of the enzymatic complement of the liver. And so it's going to be much more readily saturable. So sometimes what you'll see is this situation where a number of co-substrates or substrates plus inhibitors are overtaxing the ability of 2D6 to efficiently metabolize substrates. And because our body has various redundancy systems to deal with overflow, these 2D6 substrates will instead be metabolized by 3A4. It'll pitch in, it'll serve as the backstop or the safety net to make sure that the 2D6 substrates don't circulate eternally in our systemic vasculature and do eventually get cleared, albeit without anything like the efficiency that 2D6 would clear these drugs.
Another layer that people may not be as familiar with, would you mind sharing some knowledge about the P glycoprotein? system and considerations for our patients with that?
What I'm talking about for the most part are pharmacokinetic drug drug interactions. Now, there are also pharmacodynamic interactions where we are dealing with either synergies or combinations or antagonisms with regard to what drugs do at their end organs and end organ receptors. So, adding anticholinergic drugs will worsen anticholinergic symptoms. Combining serotonergic and noradrenergic antidepressants will hopefully provide pharmacotherapeutic synergy and you'll get responders, whereas before they weren't responding as adequately. Those are examples of pharmacodynamic drug interactions, the former generally unintended, the latter intended. So interactions aren't always a bad thing. Sometimes we embark upon them very deliberately to produce desired therapeutic outcomes. But again, those are pharmacodynamic. So they deal with end organ effects, receptor effects. Pharmacokinetic drug interactions deal with movement of drug through the body, often reflected by blood levels or levels in various sequestered domains. And there's four primary modes of pharmacokinetic drug handling: absorption, distribution, metabolism, and excretion. All of this talk about P450 in phase one versus phase two really deals with metabolic handling of drugs. There are, however, systems that impact upon the other modes of pharmacokinetic drug handling, the absorption, distribution, and excretion. And one of the most important of those is something called the P-glycoprotein pump. So this is an ATP-dependent extruding pump that is embedded in various parts of the body, but most importantly, along the luminal facing side of gut lumen enterocytes, and also in the blood-brain barrier, embedded in endothelial cells in the blood-facing side of the endothelial cell. So we are all taught in medical school that the blood-brain barrier somehow mysteriously excluded things from the central nervous system that would normally diffuse down their concentration gradients and get into the brain. Well, one of the most important of those mysterious constituents is the P-glycoprotein pump. So, as I said, it's ATP dependent because you're moving substrate against the concentration gradient in an effort to keep it out of protected domains. And for something that you take as a pill that is a substrate of this pump to get to your brain, it's going to have to pass through two sequential layers of P-glycoprotein at the gut lumen and then at the blood-brain barrier in order to get into the CNS and be an active medication. And much like we have known things like Tegretol induces its own metabolism, we've known that for decades before we ever had the nomenclature to talk about it being both a substrate and inducer of P453A4, we have tacitly recognized the effects of P-glycoprotein without having explicitly recognized that that is what's producing the effects in question. So for instance, sedating antihistamines differ from non-sedating antihistamines in one way and one way only. And that is that the sedating antihistamines are not substrates of the P-glycoprotein pump, so they diffuse down the concentration gradient, get into the brain unimpeded, and hit histaminic receptors there and sedate. Whereas the sedating antihistamines are P-glycoprotein receptors. And so you can do dose finding to figure out how much drives loratadine, say, past the first level of P-glycoprotein protection at the gut, which gets you enough of a systemic vascular concentration to hit this target organ. But then the systemic vascular concentration in question is not enough to drive enough past the second sequential layer of P-glycoprotein protection at the blood-brain barrier so that you don't get enough into the CNS to produce sedation. So that is entirely a P-glycoprotein mediated difference in terms of sedating versus non-sedating antihistamines. And there are other consequences of this, but would be far beyond what we should get into in a podcast.
Are any of our commonly used medications dependent on this P-glycoprotein system? Does it become significant that you've seen for our patients?
Oh, no, there are. Digoxin is a substrate. Morphine is fundamentally, more than any phase one or phase two stuff, morphine effects are going to be mostly a product of P-glycoprotein. Here, I'm going to use a cheat sheet real quick. Many of our anticonvulsants, but that's going to be an additive effect. Well, another example would be loperamide. The fundamental reason why it works as an antidiarrheal is that it hits mu receptors in the gut, but it doesn't get into the brain under standard conditions. I would say that, yeah, the things that I just mentioned now in terms of what did I just mention again? I had to go. Oh, digoxin, right? Yeah, digoxin and morphine. Those are going to be your two biggest ones. But I'll tell you, there have been documented interactions like the effects of omeprazole raising carbamazepine levels. Now we can explain omeprazole raising phenytoin levels through straightforward effects on phase one enzymes like P452C9, but there's really no direct enzymatic linkage that would suggest why it is that omeprazole should have anything to do with raising carbamazepine levels. That effect, which we have case examples of and has been documented, is going to be solely attributable to Pglycoprotein. And so, yeah, it comes up in various ways. It sneaks up on you. Now, it is a whole other layer of complexity on top of the P450 stuff. So again, not for those who are just trying to embark on this. Don't get ahead of yourselves. This is waiting for you as sort of the next chapter or so. But it's there and it's important.
As we come towards the end of this podcast, what would be helpful for listeners, many of whom are in medical school or in residency, to know when approaching this first chapter?
So this is a question I've grappled with over the years. I have a pretty good memory, and so this was kind of a natural thing for me to become interested in. But that's not going to be true. There are people out there who are wonderful clinicians who just it just doesn't come naturally to sit down and memorize tables and reams of information, out of the blue. Um, so as I mentioned, learning high therapeutic or low therapeutic index drugs and so forth, but how to systematize it, how to sort of trim the field a little bit so that the effort can be more high yield. So what I came up with as a not a refined or particularly well thought out, but just as a way to try to make it easier to grapple with this expansive information was to look at a set of medications that either because of their frequency of use or their recurring involvement in drug interactions are the ones that you're going to want to think about and look for. And when you see them in a regimen, look them up and decide whether or not this is something that's influencing other drugs in some way. So here, I'll even hold up the sheet. I created the Fatal 40. I don't know how visible this is going to be to anyone, but it's a list of 40 drugs. Just want to make sure people understand. It doesn't mean anytime you take one of these drugs, you're going to die. That's not what it means. It's just a catchy alliterative phrase to help, and it lists 40 medications or classes of medication that are important to recognize. We all got through med school through associative memory, right? You couldn't necessarily produce it all in an essay question, but if your multiple choice question prompted the right kind of word association, you could get the right answer. So similarly here, just getting a sense of what are these drugs, being familiar with them, so that when you do see them in a regimen with about 8 other medications, then that prompts you to say, okay, this person's on a bunch of other things, and I also see that they are on rifampin, or they're on ciprofloxacin, or they're on cimetidine, or lamotrigine, or they're a tobacco smoker, or tamoxifen, or something like that. And then that prompts you to look things up. And of course, the more you look it up, the more you eventually retain it, particularly when you look it up in the context of an actual clinical case that you're dealing with in the here and now. So yes, I would say that having that formulated list is a good thing. I could read them off if they're if that would be a good idea. Are people going to be able to record this and write it down?
Yes, people can pause, rewind, fast forward, but hopefully not fast forward.
Okay, then here we go. Without further ado, the fatal 40. Azole antifungals, bupropion, calcium channel blockers, carbamazepine, cimetidine, clopidogrel, clozapine, codeine, cyclobenzaprine, digoxin, omeprazole and esomeprazole, ethinyl estradiol, fluoxetine, fluvoxamine, grapefruit juice, hydrocodone, lamotrigine, lithium, macrolide antibiotics, methadone, morphine, nifazodone, olanzapine, paroxetine, phenobarbital, phenytoin, pimozide, quinidine, quinolone antibiotics, rifampin, ritonavir, statins, St. John's wort, sulfonylureas, tamoxifen, thioridazine, tobacco smoking, tramadol, tricyclic antidepressants, and last but not least, warfarin.
Thank you for sharing that with our listeners. I find some things really satisfying that they're in alphabetical order.
that was done mercifully. It would have been a little bit too much to handle if that wasn't the case.
As we come to a close, do you have any last words of wisdom or encouragement that you'd like to share with people just starting out on this journey?
I would say it is worth the effort. It can seem daunting at first, but conceptually, the conceptual underpinnings are very straightforward. Co-administration of substrates and inhibitors of the metabolism of those substrates will yield increased substrate levels. Co-administration of substrates and inducers of the enzymes that clear those substrates will lead to decreases in substrate blood levels. All of this stuff, or the vast majority of it, are variations on those two very straightforward, intuitive themes. It's the details. It's all the stuff that you stick into the substrate columns and the inhibitor columns and the inducer columns. But this is easy to grapple with conceptually. It's just the details seem daunting. But if you invest in the low therapeutic index drugs, if you look at the fatal 40 and invest even a moderate amount of effort, what you will get back will be very high yield information, and you will see differences in your patient outcomes. Whether you're rescuing, coming in after the fact and providing an explanation for how they can get out of trouble, or avoiding it in the first place. And part of why drug interactions don't necessarily seem that thrilling is that prevention doesn't grab you viscerally. It doesn't grab you by the throat and demand your attention. Doing CPR on someone is much more viscerally activating, whereas steering clear of an avoidable pitfall, yawn. If you're doing it right, it is going to be a little boring. You're not going to be producing problems that would otherwise spice things up, and that's a good thing. So yes, those would be my words of encouragement and direction. Is a little bit will go a long way. Just don't try to take on the world at first. Just stick with this high yield subdomain, and you'll see for yourself whether or not it's worth it. But I think you'll find it is. We hope.
Thank you so much for taking the time out of your day to come and chat with us and share knowledge with listeners. It's really critical knowledge that I think everyone could benefit from and really definitely benefit their patients. And to our listeners, I really hope that this has given you a taste of what this body of knowledge is about and why it's so critical to understand it, and that you want to take a deeper dive into drug-drug interactions. Thank you.
Thank you very much for having me. This was fun.